Hi, everyone. Welcome. We'll just give it a couple more minutes, let everyone log in. Okay, everyone, let's get started. Be mindful of everyone's time. Next slide. So welcome. Before we begin, we would like for you to know that this session will be recorded for educational and quality improvement purposes. NCUIH will be utilizing the records to continue to share and educate frontline healthcare workers throughout this pandemic. Next slide. So again, welcome to NCUIH's Project Firstline second training session in the series, COVID-19 Infection Control, with today's topic, Transmission and Source Control, which is geared towards our frontline healthcare and community health workers. We welcome our special guests, as well as our representatives from the Centers for Disease Control and Prevention, in addition to partners in our Project Firstline collaborative. We are very pleased, that you could join us today. It is our hope that this forum provides an opportunity for you to gain knowledge and foster best practices as it relates to infection control. During each session, we will hear from our Project Firstline experts, as well as offer opportunities for you to ask questions at the end of the presentation in regards to the topics we will cover. Questions can be typed in the Q&A dialog box at the bottom of your screen. And my name is Tiffani Stark. I'm with NCUIH's Project Firstline team, and I'm the Public Health Program Associate, and I'll be your presenter for today. If you do have any IT difficulty during today's call, please chat directly to Victoria Humphreys, and she will assist you. Your chat feature is located at the bottom of the screen. And also, please note that at the end of the session, a link to the post-evaluation survey will be shared with you to get your feedback on the session and assess your understanding. Completion of the survey will confirm the completion of your training on this topic, as well as assist us in improving your training needs on infection control. Finally, we ask you to enter in your name, UIO, or external organization, and any tribal affiliations in the chat box so that we can get to know each other better, as well as count our attendance. Next slide. Our agenda for today is seen here. We will begin with NCUIH's background and share our video on urban Indians, as well as taking a look at where our UIOs are located across the United States. We will follow with an introduction to NCUIH's Project Firstline staff and our subject matter experts for this session. We will cover our training objectives for this session, followed by a recap of Project Firstline, and then look at a respiratory droplet spread, contact spread, followed by an introduction to source control and personal protective equipment, as it relates to SARS-CoV-2, the virus that causes COVID-19. Finally, we will invite our subject matter experts to provide a commentary on the session, and then we will open the floor for questions. Again, please note, if at any time you have any questions, please drop it into the Q&A section at the bottom of your Zoom screen. Our staff will respond quickly with an answer, or note that it will be held for our live session at the end. Next slide. So about NCUIH. The National Council of Urban Indian Health is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUIH is the only national representative of the 41 Title V urban Indian organizations under the Indian Health Service and the Indian Health Care Improvement Act. NCUIH strives to improve the health of over 70% of the AN population that lives in urban areas, supported by quality, accessible healthcare centers. Next slide, please. We next would like to share with our special guests and partners in our collaborative a short clip NCUIH has put together to help briefly explain what is meant when saying urban Indians.
When you think of American Indians and Alaska Natives, do you picture this? Over 70% of American Indians and Alaska Natives live in cities or suburbs. Starting in the 19th century, federal Indian boarding schools governed by the doctrine, kill the Indian, save the man, took children away from their tribes and families, and the relocation era in the 1950s forced American Indians off reservations. Wait, so most American Indians and Alaska Natives live in cities? Do they all have the same culture and religion? Actually, there are 574 unique federally recognized tribal nations around the country, and many other organized groups, tribes, and bands centered in both rural and urban areas. And with more Native Americans living in cities than ever, urban Indians continue to celebrate their cultures and traditions. To learn more about how urban Indians are staying resilient and what you can do to get involved, follow the National Council of Urban Indian Health on social media.
So with that understanding, where are our UIOs located? The map shown here portrays the UIOs locations across the country for reference. We have 41 active UIOs, some of which have subsidiary sites and are grouped according to the service types provided, which are full ambulatory, limited ambulatory, outreach and referral, and residential treatment centers. Each mark denotes a location of an urban Indian organization serving the approximate 71% of American Indians and Alaskan Natives living in urban areas. These programs are culturally grounded and focus on providing holistic care, meeting the unique healthcare needs of the urban Indians, which is what we at NCUIH are also striving to do for the UIO healthcare frontline workers with this Project Firstline initiative. Next slide, please. Next, we would like to thank the CDC for their support. Project Firstline is a national collaborative led by the CDC to provide infection control training and education to the frontline workers and public health personnel. NCUIH is proud to partner with Project Firstline. The contents of this program do not necessarily represent the policies of AAAH, the accreditation body, OSHA, CDC, or HHS, and should not be considered an endorsement by the federal government. Next slide, please. Within NCUIH, we have a fantastic team representing NCUIH in the CDC Project Firstline Collaborative. So starting from the left, we have Dr. Kimberly Fowler. She's the Vice President of the Technical Assistance and Research Center. We have Zipporah Fuller, Director of Technical Assistance, Evelina Maho, Public Health Program Manager, Dionne Apedjihoun, the Senior Project Manager, myself, Tiffani Stark, the Public Health Program Associate, Melissa Watson, Public Health Project Assistant, Victoria Humphreys, Senior Communications Associate, and Alexander Zamo, the statistician. Next slide, please. For this training, I will be your host. Again, my name is Tiffani Stark, and I'm the Public Health Program Associate with NCUIH and Project Firstline. I have my master's in healthcare administration and experience in community health and project management. At NCUIH, I work with the Technical Assistance and Research Department, providing public health program assistance across the organization. Next slide, please. Dionne Apedjihoun is one of the co-hosts for today's event. Dionne has a master's in biomedical science, and Dionne's experience is in quality control, public health, and clinical research. She is also our senior project manager. Next slide. Evelina Maho has a master's in administration with an emphasis in health sciences. Evelina has a strong background in working with American Indian tribes and urban Indian health in areas such as engagement, project management, and public health. She is our public health program manager. Next slide. We would also like to welcome Karen Kwok, family nurse practitioner, as our subject matter expert. Karen has a dual master's in nursing and in public health, a national certification as a family nurse practitioner, and has over 20 years working in health equity with resilient communities, including coordinating care for UIO patients, specifically San Francisco, California's Native American Health Center. Next slide, please. So now we will transition into our training. Today's training objectives are recapping the Project Firstline initiative, describing one characteristic of respiratory droplets, describe 2 ways viruses spread from surfaces to people, understand one primary way that SARS-CoV-2 moves between people, explain one reason why infection control actions focus on keeping respiratory droplets out of the air and away from other people, and explain one reason why good hand hygiene and environmental cleaning are important to keep germs from spreading in healthcare. Next slide. The overall vision of Project Firstline is being an unprecedented infection control training collaborative, the user-centered effort in adult learning designed for the needs of busy healthcare workers and public health workers. The vision is to have a culture of interactive infection control training and education flourishing in all healthcare settings, and to also improve the national ability to fight all infection disease threats. So why now? Why Project Firstline? We are approaching a year of being in a pandemic. We must slow or stop the spread of infection disease threats, including COVID-19. Infection control works when it's done correctly and consistently. Project Firstline is here to ensure all healthcare workers needs are met, I'm sorry. Next slide, please. And this slide here reflects a few of the 80 partner network in the CDC collaborative. Next slide. CDC's Project Firstline has released 17 5-minute inside infection control video logs with topics such as what's the goal of infection control, what's a respiratory droplet, why does it matter, how do viruses spread from surfaces to people, and what is personal protection equipment, PPE. We would also like to, we'd also like to, make note to take a look at the short minutes, just the short video logs and the URL shared here in the chat box as well. Next slide, please. Before we begin, let's start the session off with a pop quiz. And also just a reminder that the Poll Everywhere information could be done on the phone or on a website if you're using a laptop. And the information's in the chat box as well. So true or false, Project Firstline is a national training collaborative. And yes, that is true. Next slide, please. So next, I would like to introduce the first topic, the respiratory droplet spread. So what is a respiratory droplet? The answer is, it is the water in your breath. The main way that SARS-CoV-2, the virus that causes the disease COVID-19, travels between people is through respiratory droplets. Next slide, please. Per the CDC, respiratory droplets are produced during exhalation. So breathing, speaking, singing, coughing, sneezing, and span a wide spectrum of sizes that may be divided into 2 basic categories based on how long they remain suspended in the air. Larger droplets, some of which are visible and that fall out of the air rapidly within seconds to minutes while close to the source. And smaller droplets and particles are droplets that dry very quickly in the airstream that can remain suspended for many minutes to hours and travel far from the source on air currents. Transmission is most likely to occur when someone is close to the infectious person, generally within 6 feet. Next slide, please. So what's a respiratory droplet? Why does it matter? Our breath contains water droplets varying sizes. Based on the sizes, these droplets will spread over varied distances. Airflow or currents can also influence the distance that the droplets travel. Contained within the droplets of a person within the COVID-19 disease are viral particles. This is the way SARS-CoV-2, the virus that causes COVID-19, travels. This is in our respiratory droplets released when we breathe. This spread gets into your nose, mouth, or eyes. SARS-CoV-2 can get into your cells once they are in these areas, and then the virus is able to infect cells or hijack cells and begin to make copies of itself, resulting in person developing COVID-19. This matters since knowing how a virus spreads will allow us to implement measures to mitigate or prevent the spread. Next slide, please. So let's focus on the key takeaways on respiratory droplet spread. The droplets not only have different sizes, but they also travel in the air for different distances. The droplets are small and light enough that they can reach other people who are close by. When someone is infected with SARS-CoV-2, the droplets that they breathe out have virus particles in them. If people who are close by aren't wearing masks or aren't behind a barrier, then they can breathe in the droplets, or the droplets can land on their eyes. When droplets carrying the virus get into someone's nose, mouth, or eyes, or travels to the lungs, the virus lands on the cells. Like many other respiratory viruses, SARS-CoV-2 can get into a lot of cells in the nose, throat, eyes, and lungs. The virus can then hijack those cells and make the person sick with COVID-19. Since respiratory droplets are the main way that SARS-CoV-2 moves between people, many of the infection control actions we need to take in healthcare are things to keep people, including our patients, our coworkers, and ourselves from breathing in each other's respiratory droplets. Next slide, please. Now it's time for another pop quiz. Get your phones and keyboards ready. So true or false? When someone's infected with SARS-CoV-2, the droplets that they breathe out have virus particles in them. Okay, and the answer is true. Next slide, please. So here we would like to know, what is your UIO doing to prevent respiratory droplet spread of COVID-19? Please feel free to type your responses in the chat. We would love to know of any innovative ways your site has implemented infection control measures if you have quite a bit to share. And we'll give some people some time to enter that into the chat box. But while that is going on, we'll move on to pop quiz number 3.
Let's go ahead and keep it in the chat. It looks like there's a connection issue on the back end here with that one.
No worries, thank you.
So just to share here, we're hearing from Aaron Wakani that his organization is doing something special. All staff is required to wear face masks. Clinical staff required to wear N95s and face shields. Thank you, Aaron. I do know we have other champion sites on our webinar today. So if they're doing anything special, please feel free to add to the chat so we can share with the webinar attendees.
Thanks, Dionne. So next we will introduce the next topic, spreading by contact. So here we want to take a moment to think about other ways that COVID-19 spreads. We have discussed the main way that it spreads by releasing respiratory droplets containing SARS-CoV-2 virus when we breathe. These droplets can travel over a varied distance based on their size and are influenced by air currents. If they land on surfaces, we can become infected through contact. We have a tendency to touch various objects and surfaces and then touch our faces. If we do not clean our hands after coming in contact with a contaminated surface through contact, we can become infected, Viruses can also get on surfaces when body fluids from an infected person, like spit and snot, get onto things nearby. So now let's take a look at how to mitigate or prevent contact spread for the virus. Since the spread of the virus is more likely through contact, hand hygiene is important. We'll have upcoming sessions that will dive deeper into the hand hygiene, looking at the use of hand sanitizers, as well as detailed steps in hand washing, so please stay tuned. For today, we will take a brief look at the CDC recommendations for hand hygiene. So the first one, wash hands with soap and water for at least 20 seconds. And 2, use the cleanest water possible. This should be from an improved or protective source. And 3, use an alcohol-based hand rub that contains 60% alcohol if soap and water are not available. The poster here depicts all of the steps of hand hygiene. Also remember, we have an upcoming webinar specifically on hand hygiene, and we will be sending out the slides following our presentation today, if you would like to take a further look into the steps. Next slide, please. So let's focus on the key takeaways for contact spread of SARS-CoV-2. COVID-19 is mainly spread through respiratory droplets. Another way you can get sick is if you touch something that has live virus on it and then touch your face without cleaning your hands first. Virus can get on surfaces when respiratory droplets land on those surfaces. Virus can also get on the surfaces when body fluids from an infected person, like spit and snot, get onto things nearby. And hand hygiene is critical in preventing spread by contact. Next slide, please. So next, we're going to take a look into source control and basic PPEs. So with source control, we look at ways to prevent the transmission of a pathogen. In its instance, it would be the SARS-CoV-2 virus. We will share some links as additional resources for you to take a closer look at options for source control. Next slide, please. The term source control for COVID-19 refers to all the ways we can prevent germs from moving from an infected person, the source, into the environment where it can infect others. Excuse me. Source control for COVID-19 focuses on wearing a mask to cover your nose and mouth anytime you might be near other people. This cuts down on the amount of virus that is introduced into the surrounding environment. Additional protection is worn in a healthcare setting based on patient care activity required. Next slide, please. Source control isn't just for healthcare facilities. Using source control on a regular basis, along with other actions like keeping physical distance from others and cleaning your hands often, will help reduce the spread of COVID-19 and other infections. Additionally, obtaining vaccines to prevent the spread of infection also helps. Next slide, please. So personal protective equipment, PPE. PPE is gear that you can use to protect yourself from getting exposed to something that can make you sick while you're at work. And it serves 2 purposes in healthcare. The first protects the individual wearing the PPE, so gowns and gloves keep it from getting to the individual, as well as spreading around the environment itself. The second protects patients and coworkers from what the individual wearing may be carrying, so keeping germs that you may be breathing out from reaching another person or in the environment. Next slide, please. So one of the many tools to protect from germ exposures. So barriers, telemedicine, cleaning, disinfection practices are all other tools that need to be used as well. PPE helps to reduce the risk of spread between the individual and the patient or coworker. And remember, PPE doesn't have a brain of its own, so think through your gear, what you're using and when you're using it. Next slide, please. We would like to thank our UIO staff shown here for sharing the photo in their PPE gear. So this is Ashley Keone Navajo, a medical assistant at Native Health, in Phoenix, Arizona. So a mask or respirator, N95, filters particles out, inhaling and exhaling, provides barrier against splashes to the nose and mouth, and require fit testing for proper seal. Eye protection, such as goggles, face shields, protection from in front, sides, and bottom, depending on action. Face shields also, or face shield alone does not offer full protection. And gown, protection from splashes and contact with spoiled items. And gloves, protects hands from exposures through a cut, irritated skin, or etc. Next slide, please. We would also like to thank another UIO staff for sharing their pics with their PPE. So this is Marlenda Luther Navajo from Native Health in Phoenix, and she is a dental assistant. So respiratory protection protects the wearer, protection that covers a person's nose, mouth, that helps to reduce the wearer's exposure. This type of protection can include filtering face piece respirators, FFRs, like N95 respirators. Next slide, please. Now I would like to hand the presentation to Evey Maho, who will be sharing her insight on American Indians.
And Tiffany, right before Evey starts, we do have some additions in the chat to folks who have responded regarding what their sites, and if that's okay, I'll go ahead and read. Aside from what Erin added, we have Kiri Smith, who's added that her site performs daily temperature checks. They have wearing of masks and gloves, placements of desks greater than 6 feet apart with dividers. They have use of shields and gowns when they're face-to-face with clients. Additionally, we have another champion site on here, Johnny Delgado. At their site, they have air purifiers throughout the offices to cover all of their office space. Staff is also required to wear masks at all times. Face masks, gowns, booties, and gloves are provided. Gloves must be worn when away from desks. Each desk also has hand sanitizer with dispensers located at all main office door entrances. Thank you for sharing. That's awesome. Congrats.
Thank you for sharing. Yes, thank you. Let me turn on my video here. I appreciate the PowerPoint presentation and going through all of the protective barriers that we've included in this presentation. Our workforce comes from all walks of life, and we are all employed by our urban Indian health organizations founded by our American Indian leaders and community members, the grassroots people. And so as American Indian member of the communities from all these different parts of the country, our practice, original practices as an American Indian and Alaskan Native have been a part of our makeup in preparation for war or an ailment or a sickness or an unknown or imbalance of some sort. And so these were what we term as our original public health protective barriers. And I think as employees, as leaders, and those of us who work in urban Indian health organization, it's a good way to convey to your staff, your colleagues, about the importance of practicing the current day and how we protect ourselves in the healthcare industry against COVID-19, against other ailments and other types of infectious diseases. And so I wanted to just quickly make a comment that in every tribal community, the way we prepared for these unknown things, sickness, ailment, and harmful things in our lives, there's lots of traditional practices, and they're infused in the evolutionary stories, our oral. Some of us share these through oral history, and our people's journey. They come in forms of winter stories. They come in form of ceremony or customs and practices. And some of these things could be as simple as smudging. Some could be early morning prayers. There's a lot of things that we utilize. It could be some tribes might utilize a certain type and form and type of paint to put on themselves, and it represents protection and preparedness of some sort against whatever they might be facing at their point in their world, in their life. And so all of these practices are a part of us still to this day, and it could be incorporated into some of our modern day recommendations we have today for you. Ultimately, it restores balances with yourself, mind, body, and spirit, our families, our connections, our relations, and our community, and the greater environment, of course, the world and the universe. That's really our mindset and our approach when we talk about some of these original practices that we've done. And so I just wanted to comment that it's important if you are from these communities to share this and to make it a part of your culture and practice in your organization, and help your staff and your colleagues realize the importance of some of these practices that Tiffani had covered today. I will go ahead and pause here, and feel free to reach out for additional comments or questions. And I'm going to allow our subject matter expert, Karen Kwok, to also share some of her comments as well. Thank you.
Thank you, Evey, for sharing those insights of the Native community. Really appreciated the rest of the team's presentation here on the notes. And I wanted to provide some summary thoughts on the topic that was shared today. And before the audience gathers some of the questions that they might have, just wanted to touch on briefly through Project Firstline, the lens we have here, we can see how the clinic is a family unit of staff members involved in controlling the spread of infection and keeping patients, families, and elders, colleagues, and the community safe and healthy. The pre-COVID protocols, measures for infection control are still in practice here. As we discussed, there are sources for infection that we will discuss in later trainings, but these same principles of hand hygiene, personal protection, and environmental cleaning with designated patient exam rooms and cleaning agents are still the same. We discussed specific modes of transmission, such as contact, droplet, and airborne spread of germs. With COVID, we highlighted respiratory droplet spread to people via the air or on surfaces. And with COVID's movement between people, we emphasized the importance of how infection control is in keeping respiratory droplets out of the air and away from people. Now I invite the audience to share their infection control best practices and or any questions they might have. Thank you.
Thank you, Evey, and thank you, Karen. So now we would like to open the floor for questions. So please type your questions in the Q&A section in the chat box, and Dionne will facilitate questions and direct them to our SME.
Thank you, Tiffani. Thank you, Karen. First question for you. How is the use of PPE different for a rehabilitation center when compared to a hospital?
Great question. Thank you for bringing that highlight as to how PPE might be used in different settings. And I want to emphasize again that even before COVID, everyone here has got this. We have the knowledge as to the function of PPE. It's still the same. We are trying to protect ourselves, those that are working in healthcare facilities, from germs and preventing its spread to our colleagues, our patients, our community. Its rationale is still the same as well. So in a rehabilitation center, the risk of infection spread, it might be lower, where you might have already a barrier of plexiglass between booths to divide and keep the 6 feet of spacing and distance between staff members. But it would be different if you were in a hospital setting where the function of the PPE is to reduce the high content exposure that might occur with contact through patient care activities like bathing the patient that is confirmed to have COVID in the inpatient setting. So again, before COVID, the function, the purpose still the same for personal protective equipment use. However, it is determined by the level of risk, the setting in which the PPE is used, that you would deploy the use of the PPE dependent on the setting. So I hope that that is clear. And please feel free to ask follow-up questions if needed.
Thank you, Karen. Next question. Can you share an example of how I implement policies and infection control utilizing CDC state and local jurisdiction?
Absolutely. So I work in the outpatient setting, but we do see patients who are confirmed to be positive with COVID testing, as well as those who were exposed. And so where we are in communication with the different authorities is that CDC provides us with the guidance. For example, for my patients, even if they were exposed and had been tested negative yesterday, but are still pending that follow-up testing, we still use universal masking precautions. That would be true for the exposed and definitely for the person that is confirmed to be COVID positive. Then regarding the state local jurisdiction, specifically for me in DC, it's the same. But with the local jurisdiction, we have policies as to working together with the disease control investigators on monitoring patients, both that were exposed and currently tested negative and are in quarantine, as well as those that are confirmed positive, and on isolation precautions, making sure that they are safe, that the symptoms that they might manifest is still safely being monitored on an outpatient level, and that they are immediately referred to the hospital setting should they manifest any emergency symptoms like shortness of breath or neurofocal deficits, for example, not being able to lift one side of their body or are confused. Lastly, we also in our specific institutional setting have policies in which, under the jurisdiction of DC Government Department of Health, along with CDC guidance, that we manage our protocols for those that are exposed and the testing that needs to be done for them. And then also for those that have been confirmed positive with COVID, what are the protocols before they can return either safely to work or safely to the community. So those are the communication protocols that we have with ensuring CDC guidance is observed integrated, making sure that we observe the local jurisdiction, DC Department of Health, as well as institutional policy to make sure that the patient is safe and that we are utilizing infection control to keep our staff and colleagues safe in the healthcare facility. Thank you.
Thank you, Karen. I do have a question that popped in for Evey. Evey, I'll direct this question to you. It's from Dawn Lula, and we can unmute her if we have additional questions. What are your options for staff mental health, especially for staff that attend ceremony often?
Sure. It's really important that when we're talking about, let me start off by making the comment that it's really important that when we use the word ceremony that we're aware and making sure that we are well-versed, and if we are not well-versed in some of these ceremonial practices or customs, that we reach out to a regional or local traditional practitioner that may come from those communities, those tribal nations, so that they guide how to approach these things and when it might be appropriate. There are, and I can send you, Dawn, some materials that specifically speak to ceremonies. I think it's really important that for some traditional practitioners, some of the things they've implemented is making sure that there's no gathering in large amounts of people, that everybody wears their masks, and they're 6 feet apart. You know, there's these, similar to our urban Indian health centers, they've put in similar types of protocols in place so that it's a safe environment for them to partake when it comes to attending ceremonies. Those are some top things off at the top of my head, but there are a couple of organizations I know in Indian country that have put out some guidance for the community, and I can share that with you. As far as the options for staff mental health, could you expand on that question? I'm not exactly sure what you mean on that.
Are we able to unmute Dawn's microphone, Victoria?
And maybe you could.
She's unmuted.
I'm not sure if you can hear me. Can you hear me?
I can
Yes,
hear
we
you.
can.
Yeah.
Okay. Sorry, I'm speaking into a computer and there's no obvious microphone. I was just wondering about the mental health of our staff. I mean, we're all getting COVID fatigue like everyone else. And it's, you know, when you're in an urban setting and you just tend to feel more isolated. And the options for mental health appear to have become limited to, of course, less face-to-face communication. But there has to be a way for us to feel connected without that interaction. And I was just wondering if there are any other considerable options besides video chat. I know it may not be, there may not be any other answer.
There's a recent resource that I came across, and I'll share this with you too, Dawn, and we can definitely share it with the rest of the folks on the call. But there are some resources that recently came available for healthcare workers where they're addressing the welfare and well-being of our workforce. And I can share that with you. From an American Indian community type of perspective, I think one of the things that's really, really key and important, and it works across all cultures of the world, is that we find our sense of calm. We find our sense of home. We find our sense of well-being within ourselves. And so taking a few moments to start the day off, whether it's virtually or in person, like in the clinic setting, making sure that we take care of ourselves by breathing is important. We might debrief on a daily basis. That's another clinical practice that's used widely, like with nursing division and some of the physicians, like in the ER department. Those are some things that help people share and vent, creating a time and a place, whether it's virtually or outdoors, where folks are spread out apart, and being able to convey how they are feeling is really important as well. Creating a buddy system might also be an option, where employees are able to create a network of individuals where they can bond and talk about certain aspects of their work, or things that they feel comfortable sharing. The other thing I know that some of the larger hospitals throughout the country are doing is that they're making sure that a part of their leadership, like the C-suite leadership teams, they're making sure that wellness or public health, maybe representative, or employee wellness professional is a part of the team. And making sure that as an organization, a healthcare system, they're also infusing the importance and noticing the importance of employee well-being, that those mental health states are being addressed, that it's a part of the strategic plan, because at the end of the day, we have to keep our workforce healthy. Mentally, physically, emotionally, and every aspect of it. So something to consider if you are a leader and you are in that capacity to invite some of these key individuals to begin to be a part of that. That would be something definitely to do and begin with as well. I'm very open to discussing more and sharing more resources with you, Dawn. So feel free to reach out, and I'll just put my email address in the chat box as well.
Thank you, Evey. I do have I'm sorry, Karen, did you want to add to this?
Yes, please, sorry, if I could piggyback on what Evey was saying. And first, I want to thank Dawn for bringing up such an important issue. And it's near and dear to my heart as to the healer in all of us in the healthcare facility, all staff, that we need actually healing too. And the social isolation has really magnified that need. And so I actually have 3 ideas based on the different target groups. So as an individual, I actually saw, and I loved the presentation that NCUIH had with Sean Ironmaker regarding healing during this time. And they had brought up smudging, as well as music, and what healing that music plays in our own health. A second strategy with my patients here at my own institution, with the distancing of appointments, we do actually have the capacity to have an extra room in which we utilize that as a safe space for my patients who are utilizing mental health virtual telehealth. So before COVID, my patients who were able to in person go to the counseling center, now after COVID, the counseling center has gone completely virtual. But in social distancing and staying at home, those same patients don't feel like they can maintain their privacy when their roommate can overhear them when they're on the phone with their counselor or psychiatrist. So we actually have a room designated for mental health virtual consults. The patient still goes through the same protocols, temperature checks, making sure through the screening that they haven't been exposed or they don't have any COVID worries worrisome symptoms, but then they have that safe space with our facility to seek the mental health services. Lastly, I do have a resource, and I can provide as a link later on as a follow-up from the webinar training, is that Project Respite is a national initiative that one of my psychology colleagues had brought up, where specific to your question, Dawn, that the healers also need healing too. And so I will share that resource later. To other questions in the audience, I'll let you have the floor, Dionne. Thank you.
Thank you, Karen. I just wanted to point out that Zep Fuller, or Director of Technical Assistance, had asked the questions if there are any other UIO participants, CEOs, or would be interested in a leadership series on mental health, or if any other staff members or champion representatives who are on this webinar call, if they're interested in mental health for frontline workers as a series, something that we could probably look into in providing more resource or maybe hosting. If you are interested, go ahead and type your name and contact information here in the chat so that we can follow up with you with this specifically. Going back to questions that are coming in, we can take 2 more. We have 6 minutes, so keep that in mind. What is the difference between source control before and since COVID?
I can take that. So before COVID, as well as after COVID, there is an underlying similarity and consistency where the rationale for use is for protecting yourself from coming into contact with germs, from preventing its spread to patients, colleagues, and community members. So that's still the same. And it's rationale, the thought process in how you select the PPE is dependent on the risk of the type of exposure, the right equipment depending on that exposure, and that right fit. So those are still similar. That's the same knowledge that we do already have. So we do got this. After COVID, there has been universal masking, social distancing, and environmental controls such as the 6 feet spacing that Carrie brought up, where there's the plexiglass barriers and further separating booths. And what Johnny Delgado had brought up in terms of ventilation, and we'll be diving into those topics later as well. And then what Aaron had brought up as well, the different types of respirators. It wasn't brought up specifically here, but poppers. So the powered air filtration masks. So those are some of the differences after COVID. Thank you.
Thank you, Karen. If anyone else in the audience have questions, please feel free to type in the chat. In the interim, we'll take one more, Karen, and then we'll head to upcoming events. How does understanding ways germs spread inform infection control? And we can probably wrap this question up in a minute, if possible. Thank you.
Great question. So we learned here in this session the ways germs are spread, whether it's by contact, droplet, or airborne, and that helps us determine what is the appropriate PPE use. Is it all the above? Gloves, gowns, eye protection, face shield, or depending on the activity, which is not involving high contact, high risk, like bathing a patient in the inpatient hospital setting with a confirmed COVID case. In contrast to that, if you were in the setting that you were behind a plexiglass and you were 6 feet away and sharing the demographics for registration, you wouldn't necessarily have to wear booties and a gown. So I hope that that helps you differentiate between what are the different types of how germs are spread, and then the proper PPE use depending on that risk.
Thank you so much, Karen. And I do not see any more questions coming through, but please feel free to email us at ipc@ncui.org, and we will get an answer back to you if there's any question that you have that we haven't touched on. And I'll transition back to you, Tiffani. Thank you, Evey. Thank you, Karen.
Thank you everyone for a great discussion. So next slide, please. So here we have some additional resources on Project Firstline in the CDC. Next slide, please. And coming up next, for the next live webinar, we'll focus on each piece of personal protective equipment, PPE, recommended for caring for patients with known or suspected COVID-19. So what it does, how it works, what its limitations are, and what healthcare personnel need to understand in order to select the right PPE and use it correctly. Next slide, please. And NCUI's upcoming events. So for Project Firstline, our next live webinar will focus on PPEs, and that will be on March 16th, 2:30 p.m. Eastern Standard Time. Additional Champion Echo sessions, which are closed. The next session, March 4th at 2:30 p.m. Eastern Standard Time. And CDC Project Firstline partner activities will notify via NCUI newsletter and emails. SUNY COVID, the second mental wellness. The topic will be understanding suicide and substance misuse among urban Native youth. That will be February, I'm sorry, that has already passed. I don't know if that was there. And then NCUI accreditation series, the spring series. So please register. The registration is open. And the first one will be on February 25th. And here we have the post-session evaluation link. So please let us know how we can make these trainings better for you, and go to the link above after this session to complete the survey.
Just a reminder that completion of the survey indicates to us that you have completed the training. Thank you so much.
Thank you all again for your time, and we look forward to seeing you next time. Thank you.
Thank you.